Hello, and welcome to the University of Washington, Washington Area Cardiometabolic Project ECHO Session 3. I'm Nicole Earhart, one of the adult endocrinologists at the University of Washington Diabetes Institute. We're so excited for this program to continue. For every session, we do ask that you help us empower our patients with cardiometabolic disease, and also note this is a safe space, and that there's zero tolerance for making people uncomfortable as we build this learning community together, which is really the heart of the ECHO model. Today, I'm going to be giving the brief lecture on older diabetes medications and sort of setting the stage for diabetes medication management. As well, Dr. Chuck from the Health Point organization will be presenting an interesting case today. And now I'm going to have the rest of the panelists introduce themselves, so they will be helping us direct the discussion. So Dr. Laura Montour, please introduce yourself.
Hi, Laura Montour. I'm a family physician, and I'm also the co-director for the Center for Weight Loss and Metabolic Surgery. My sole job now, I'm a family doctor, but I do obesity medicine.
Thank you. And Dr. Gleo Nulendi Bland, please introduce yourself. She's coming to us from Washington, D.C.
Thank you, Nicole. I'm Dr. Gail Nunley Bland. I'm an endocrinologist, Division of Endocrinology at Howard University.
Thank you. And now Dr. Paul Chichanowski, could you introduce yourself, please?
Yes, thanks, Nicole. My name is Paul Chinovsky, and I'm a psychiatrist, and I've had the pleasure to work at the University of Washington Diabetes Institute for most of 28 years.
Thank you, Paul. And now Dr. Christine Lamonte, could you introduce yourself? You're one of our new panelists.
Hi, everyone. Nice to meet you. My name is Christine Lamonte, and I'm an adult nephrologist at the University of Washington. I'm also a clinical researcher with a focus in diabetic kidney disease.
Awesome. Thank you all. What a great panel we have today. And without further ado, we're going to go ahead and start the lecture. So I'll go ahead and start. As you know, I'm Nicole Earhart, one of the adult endocrinologists at the University of Washington, and I'm going to be setting the stage today about our diabetes medication management, and we're going to be talking about older diabetes medications for type 2 diabetes. Here are my disclosures. So our objectives today are really being able to understand the nuances of our diabetes medications, because there's always clinical pearls and ideas that we hopefully can give you to bring back to your clinical practice. I'm going to do this in the setting of setting the stage and looking at them not for just their glycemic management, but also in the sense of looking at them from a renal, cardiovascular, and liver perspective. So let's go ahead and get started. So what I tell people is, when we're talking about diabetes management, lifestyle is sort of our cornerstone along with diabetes educations. And so any medication is just an adjunct for our lifestyle, because those small changes are going to make things even more effective for our diabetes management. And why do we care about lifestyle? Because we know as little as 5% weight loss will improve our glycemic indices, our cholesterol, our blood pressure. And then as we get added weight loss, we get more and more benefit for our health. And so we want to continue the discussion both about medication management and lifestyle at every clinical visit. This will be my only slide about insulin, and what I tell people is, do not be afraid to use insulin early, right? So in those people that are catabolic, meaning they are losing weight, they have significant polyuria, polydipsia, these people have a sick pancreas. And so insulin is the right thing, at least in the short term. And typically we would think about initiating insulin in those that have random sugars above 300, fasting sugars above 200, and then if they have A1Cs greater than 10. But the most important thing is to reevaluate the patient's glucose control at every visit. And early on, think about those insulin-sparing agents once they get out of that catabolic state. So I show this slide when we're talking about diabetes management because this was a ADA figure from when I was junior faculty. And what it shows you is, right, metformin is on top with lifestyle. So you're like, yes, I know metformin and lifestyle. But then you're like, yes, there's all these medications that are available for our diabetes management. But what this graph doesn't do is doesn't show us how to individualize the treatments based on the patient's characteristics. And as well, what you see on the side is this very like monotherapy, dual therapy, triple therapies, this sort of inertia when it comes to escalating medication for diabetes management. And because of the body of evidence out there, our diabetes management has evolved over time. And we think about how to select the appropriate types of diabetes medication based on our mechanism of action. You always go back to the pathophys because that will always help you determine a good choice of medication for your diabetes. But as well, we are focused on the efficacy. So on average, how much does it lower the blood sugar? And then the next thing is we're very aware because one hypoglycemic episode is catastrophic. It is a lifetime of hyperglycemia that causes our complications. So we really want to know the risk for hypoglycemia for each individual drug. And then because sort of the core of diabetes can be weight, we also want to know what effect these medications have on weight. And our newest way of thinking about things is outside of glycemic control. So those cardiovascular effects, the use in CKD and for renal disease, and then the emerging evidence on liver disease and how they work in those as well. And finally, it's really important. We know how busy you are in your clinical practice, but you have to be able to have a discussion with patients about the common side effects and then the serious side effects, because we all know that sometimes what happens is patients read a label or they see an ad on TV and then they get scared and they don't ever start the medication. So 3 months later, they come back to you and you're at the same point you are. So that's why you want to keep all these things on the forefront of your mind when you're thinking about individualizing things for diabetes management for patients. And look at this great figure now, still very busy. The ADA tends to be a little busy with their figures, but now what they're showing is individualizing characteristics in order to choose medications. And this is where I'll say metformin is no longer on top. It's still a very good medication, but the first thing you want to do is assess their cardiovascular and renal risk, and that's how you first select the medications for those things outside of glycemic control. But then what's great is the ADA has also started to stratify within the classes of medications, both by efficacy and weight loss potential. And you can see that deglutide at high dose, semaglutide, which are GLP-1 receptor agonists, and then also tirzepatide, which is our GIP-GLP co-receptor agonists, are on top for efficacy, and then semaglutide and also tirzepatide have the highest efficacy for weight. And so we want to keep this in mind when we're choosing our medications. Additionally, like I said, outside of glycemic control, our first choices are now our GLP-1 receptor agonists and our sodium glucose cotransporter inhibitors when you have significant cardiovascular or renal risk. But now let's talk about all the rest of the classes of the medications, right? So I show this slide because my mentor had like insulin and then maybe sulfonylurea and metformin available. But by the time I was a fellow, there was this explosion of diabetes medications available. And so we have so many things to choose from. And because we have so many classes of medications to choose from, we do have a lot of targets in our body as well. Now, this isn't going to be a pathophysiology lecture, but just show this to show that we have many different ways of targeting our hyperglycemia and dysglycemia in the body. And this is a sad statement, right? Despite having these advancing diabetes medications, technology, and policy, unfortunately, we have yet to turn the corner on improving diabetes outcomes. And so that's why we're here today, right? To learn more so that we can have more people reach their glycemic goals. So let's step back and look at our older diabetes medications now. So our biguanines or metformin. And when you're thinking about the medications, why do we like metformin, right? It has good efficacy. It has a low risk for hypoglycemia. Every drug has a risk for hypoglycemia. It has a low risk, though. It can occur in the same of fasting for a long period of time and in an exercise, but it has a low risk. And why is that? Well, the mechanism of action is that it suppresses gluconeogenesis in the liver and then also improves insulin resistance. So you can see by the pathophys why it has a low risk for hypoglycemia, but why it's a very effective medication for diabetes. Now let's talk about the common side effects. So one of the most common things that I get from patients is that they're intolerant or they have too much stomach upset from the metformin. So the first thing you want to assess is what type of metformin they were on. Many people were on the immediate release metformin, which tends to have more GI side effect profile and more diarrhea associated with it. So I always tell people if they're willing and they haven't been on the extended release to do a retrial at a low dose. So the idea is to start slow and go low. So start at 500 milligrams extended release once a day, and then every 10 days if they're feeling well, and tell them you may have a little bit of discomfort, but you want to give yourself 10 days for your body to adjust. If on the lowest dose after 10 days, there is no benefit and you're still having GI side effects, go ahead and stop it. But usually if you couch it that way, they're able to do that for the 10 days and the majority of them will adjust to the medication. And then every 10 days you can go up on it to first 1,000 milligrams daily, and then typically you get a good effect at 1,500 milligrams. So a lot of times that's where I'll stop because you get good effect from it. And then pill burden is really important to people. So, there are 750 milligram tablets extended release available, and those are actually available through the Walmart formulary, so you can get them very cheaply. And so you can do 2 tablets once a day with breakfast or once a day with dinner, and it takes down the burden of their pill burden and then also increases the likelihood of them to take it if it becomes only a once a day medication rather than a twice a day. So now let's talk about the sort of serious but uncommon side effects of this medication. So the reason that people are concerned about metformin is this rare risk for lactic acidosis. And the old guidelines used to say do not use with an absolute creatinine of greater than 1.5 in males and 1.4 in females. Luckily, this is very, very outdated now. And so now they tell us that you can initiate metformin up to 1,500 milligrams, so at a reduced dose, at a GFR of 45, and then you can continue it in people whose GFR, as long as it's above 30. And this was because they did a meta-analysis of the risk for lactic acidosis in the population, and they found the risk was very low. So this is where I'm going to pause and ask our nephrology expert. I often hear metformin hurt my kidneys, and we know that's not true, but how do you talk about that with your patients?
Yeah, I feel like I hear that mostly in the context of metformin having been discontinued. And that's where I like to clarify with the patient that the reason for discontinuing metformin was likely because their GFR went below 30, which is the cutoff for safety for adverse events, not that metformin was what caused their kidney injury. And I like to reassure them that metformin is, very well tolerated by the kidneys. And the only association we really have with kidney injury is in the setting of lactic acidosis, which, as you've described, is a rare complication.
Great. Thank you for that update. And I agree. It's a discussion I commonly have with my patients. And I understand as busy primary care providers, you may not have the same luxury as time. But I do think when you do stop the medication, just clarifying that for the patient, will really support patient goals and everything.
Yeah,
So
I also find that that's a good opportunity to educate my patients that diabetes is really the cause of their kidney disease, because what I've experienced is that, despite hearing, that from multiple providers, because the kidneys are this really mysterious organ that doesn't cause pain when it's, when your GFR is low, a lot of folks don't really have that association of diabetes causing their kidney disease. So I just want to reinforce that that's really important to communicate to the patients.
thank you. That was great expert advice there. And then briefly for liver disease and metformin, interestingly, there has been studies that have shown that there's been a reduction in hepatocellular carcinoma with metformin and the reduced incidence of overt hepatic encephalopathy in patients on metformin. So it is a good medication, but what we want to always say when it comes to like advancing disease or advanced cirrhosis, so child stage B or C, we want to think about potentially stopping it just because of the risks associated with using it in a progressive disease. So in early on, good, later stages, not as good. And finally, from a cardiovascular standpoint, so I think we've all heard of UKPDS. That was our largest complication trial that was done in our type 2 population, where they followed people with more intensive control and then less control. And they gave the group of people metformin. And what they found is that there was lower all-cause mortality and lower cardiac death associated with the group that was on metformin. It was actually pretty impressive. The number needed to treat to avoid one death was only 14. And so this is great data. But, it's not something that we've seen as much in our other studies. And so what we tell people is that was when it was initiated early in people. And so we do want to think about it as potentially being cardiovascular protective, especially when added early in the disease therapy. So what is my summary of metformin? Try again a low dose of the extended release in those with GI intolerance, because if you are able to use it to lessen the dose of insulin, what it does is it reduces the risk for hypoglycemia, right? So any little bit of medication, especially if insulin is your next choice, will reduce the risk for hypoglycemia. You can continue it until the GFR is less than 30, and you can start it with as long as the GFR is high, as greater than 45. We like it because it's an inexpensive medication. It has a low risk for hypoglycemia. And what I didn't mention is it does cause weight loss, maybe about 3 to 5 pounds. So every little bit helps. And that's always a benefit and bonus for our patients. And then I do continue the use when we initiate insulin. That's another common question I hear is, metformin doesn't work for me. And so again, as I said, you want to use it as an adjunct to reduce that cumulative insulin dose. And that's how I discuss it with patients. You may still need insulin, but hopefully your dose is a little bit less than if you weren't on the metformin. There may be cardiovascular benefits, and how this equates in my clinical practice is because of those potential cardiovascular benefits when used early in those patients that I see with prediabetes, especially if they have a history of gestational diabetes, they are obese, so they have a BMI over 30, and they're younger, age less than 60. Even in my prediabetes patients, I will offer them the therapy, and then we can talk about the risk benefits in the setting of pill burden versus, slight potential improvement from a cardiovascular standpoint. So now going on to our sulfonylureas. So sulfonylureas are also very good medications in the sense that they have a high efficacy, so greater than 1% A1C lowering. And how they work is they flog the pancreas, right, to produce insulin. So that's also the negative of them, right? Because they do have an increased risk for hypoglycemia because they're just causing the pancreas to continue to produce insulin. And then also, because you're continuously producing insulin, they tend to have a little bit of weight gain associated with them. So how do I use my sulfonylureas? Well, we like them because they don't have any GI side effect profile, and so they're well tolerated that way. And then as well, it's sort of fallen out of favor to use glyburide because that one has a slightly higher risk of hypoglycemia. So typically we use our glimepiride and glipizide, and I actually preference using glimepiride because of the first pass. It actually helps a little bit more with the postprandial sugars because of its physiology than glipizide. So I tend to preference using glimepiride in those that have normal renal function. Again, remember, the most common side effect associated with it is hypoglycemia, which can be a very serious side effect. And then about 30% of people will have a crossover with sulfa drugs in this class of medication. So be aware of that, as another allergic reaction could be a side effect of this medication. So then let's take a look at sulfonylureas in the setting of efficacy, right? And because typically it's an add-on to metformin, and you can see even as an add-on, you have almost a 1% A1C lowering. So again, a very good medication to use from an efficacy standpoint. What about in kidney disease? So as I said, glyburide has sort of fallen out of favor to use. And glimepiride is typically what I will start, but I'll start it at a reduced dose, even half a tablet, so 0.5 of a milligram to 1 milligram for stage 2 or 3. But once they get to stage 4, with an eGFR of less than 30, then you really want to switch over to glipizide. And you don't want to use the extended release form of glipizide. You want to use the short acting at a low dose. Usually I'll start at 2.5 milligrams twice a day in this population if we continue the use. Again, this is where we may be thinking about insulin as a replacement. I do use sulfonylureas in the setting of basal insulin. Some people do not, but the most important key is to choose an appropriate conservative dose of the insulin, and then also a low dose. Like for the glimepiride, I probably wouldn't go over 2 milligrams a day in someone who I had on basal insulin. But why do I use it with insulin? Because it has that, again, postprandial benefit because of the first pass physiology for the glimepiride. I have not actually used the short-acting secretagogues in quite some time, just because there's other medications now that we have that are newer. But just to point out, our nictiglanide and repliglanide, which are Starlux and Prandon, are short-acting secretagogues and can be given in those that have renal dysfunction. And but the limitation is you do have to take them 3 times a day with meals, which is why I think they've fallen out of favor. And then I'm going to phone a friend again and just ask Dr. Lamonte, any thoughts about sulfonylureas? How do you use them in your practice as a nephrologist?
Yeah, so in my practice, I see folks with diabetes and chronic kidney disease. And chronic kidney disease we define as a GFR less than 60 or any albuminuria. So that's even albuminuria greater than 30. So could be, minor or microalbuminuria, but albuminuria nonetheless. So I see people with diabetes and CKD, and what we prefer in those folks for glycemia management is metformin, SGLT2 inhibitors, and GLP-1 receptor agonists because SGLT2 inhibitors and GLP-1 receptor agonists have kidney protective effects. And our CKD population is at greater risk of hypoglycemia, which can be exacerbated by sulfonylureas. Sulfonylureas may be the preference for some patients, though. That's usually because of lower cost. And if they want to avoid injections like with insulin or with GLP-1 receptor agonists.
And that's great advice. And we're going to be talking about our sodium glucose cotransporter inhibitors and our GLP-1s and further things. But again, what we have to highlight is we can use the medications that are best, but also we do have to think about cost. And so sometimes cost is prohibitive. And so we want to utilize all our medication classes as safely as possible and better to best support and individualize it for patients. So this last slide here is just medications we don't tend to use, but I wanted to throw it out there in case anyone had any questions. So our glucosidase inhibitors, which is our acarbose or Precose, occasionally we'll use this in postprandial hypoglycemia, but again, the limitation tends to be GI side effects and it has to be dosed before meals. So I haven't had a lot of success with that. And then our dopamine receptor agonists, which classically are used for our prolactinomas, but they've also been shown to have some glycemic lowering effect. But I, again, have not initiated them primarily for diabetes effect. And then finally, our bile acid sequestrants, again, this decreases our cholesterol and our glucose absorption. The trade name is Well-Call for them, but they are very burdensome in the number of tablets you usually have to take in order to see effect. And so again, it's not something I use. So I'm just going to, at the end of this, throw out to Gail, as our other diabetologist in the room, do you use any of these medications, or can you think of a time when you would use any of these medications?
I haven't used those in many, many years, and some of them are quite costly too. So, no, I haven't used them.
Yeah. And so, again, we want to have all things available for our patients, but we want to think about that. And I just wanted to end with a conclusion on our sulfonylureas and the liver disease, similar to the metformin, except for if you notice, they have actually increased odds of hepatocellular carcinoma developing. And, in general, if we can avoid it in liver disease, especially progressive liver disease, we probably should. And so metformin may have plus minuses in liver disease. Sulfonylureas don't have a lot of positives. And then obviously, because of the effect on gluconeogenesis, as liver dysfunctions increase, you'll have an even increased risk for hypoglycemia as our liver disease progresses. And then this was our final thing about cardiovascular benefits or neutrality. So there was this old thought that because of ischemic preconditioning, the sulfonylureas in our first and second generation sulfonylureas would increase that cardiovascular risk actually. But they've done meta-analysis on the generation of sulfonylureas we currently use, and they've seen no increased risk of cardiovascular disease. And then there was a randomized control study where it was actually competed against linagliptin, looking at cardiovascular outcomes. And this was glimepiride and linagliptin, and they actually found that they were both neutral. So in general, what we see is neutrality from cardiovascular harm. So that's good. So overall, my summary is sulfonylureas have their place, right? You can use both metformin and sulfonylureas, preferentially glimepiride, in appropriate doses of insulin, but not everyone does it. Not every diabetologist will that. I use glimepiride preferentially because of the post-meal benefit. You want to start at a low dose, especially if the eGFR is less than 60. And once the eGFR gets to less than 30, you want to only use glipizide 2.5 milligrams short acting twice a day at most. It does cause weight gain. It's neutral from a cardiovascular benefit. It can be cost effective, but the biggest risk, which may also increase costs, is our risk for hypoglycemia. So at this point, I'll open it up for any questions. Does anyone have any questions for me? I'm just going to take a look at the chat. There is someone who said, for the unusual medications, I have some patients who absolutely refuse insulin injectables. Would polypharmacy with these medications be reasonable options to offer? I will often already have them on metformin, SGLT2 inhibitor, pioglitazone, and a DTP4 inhibitor, as insurance won't cover oral semaglutide. So I was wondering if adding any of these might be of benefit. When we get up to 3 to 4 insulin-sparing therapies, my suspicion is they're glucose toxic, or they are insulinopenic and they may need insulin. And so I would do more evaluation to try to partner with them about insulin, right? And or if we see good insulin reserve, talking about the weekly GLP-1 receptor agonist or the daily. But I don't think there would be enough benefit from those other medications we discussed if they're not controlled on, 3 to 4 medications. Gail, do you have a comment about that?
I agree, Nicole. And I don't know, in some instances, if any of them would be willing to take the oral GLP-1s. I mean, that's another option that you could provide for those who refuse injections. And sometimes I use that when they're on, several medications, and I'm trying to get them to get close to. But yes, they may be insulinopenic and they're going to need insulin. And sometimes just looking at their C-peptides and showing them that none of these are going to work and we really have to use insulin.
And they did comment that unfortunately the oral semaglutide was not covered by the insurance. Sometimes you can say fear of needles and ask for a prior authorization for the oral semaglutide if they're not controlled, and you could go to a peer-to-peer or just list the medications they're at and what their A1C on. But sometimes it can be plan exclusionary, and then there's no opportunity to do that. The last question we'll do, because we want to get to our great case, is there secondary failure of sulfonylurea still a concern? I believe that question means that over time, the sulfonylureas become less effective. So I don't think it's so much the sulfonylureas not working as well. It's that the natural history of the disease process is to become relatively insulinopenic, especially as we age and we've had our diabetes for a long period of time. There's no data that it causes the failure of the pancreas, right? But it may be less effective as we age if we're not able to produce the right amount of insulin. Is that your understanding of it as well, Gail?
Yes, I agree.
Okay, so at this
Hey,
point,
Nicole, there's one more question actually about patients who have an injury to the pancreas and using sulfonylureas and GLP-1s.
That's a great question. So everything has a relative risk, right? And a relative benefit. And so we know when people have had like a pancreatitis that they are that's the number one factor, they're at higher risk for pancreatitis. And so you have to discuss that with them. But sometimes the efficacy of something like a GLP-1 receptor agonist would be beneficial, especially let's say it was like from gallstones and they had their gallbladder removed. Now you can still get gallstones and still have effect and a risk for pancreatitis, but we would do a paired partnership, and I would say it may not be the best medication choice for you, but if you're willing to accept that slight increased risk, then we should consider it, especially if we've tried alternative therapies and they've not made you to A1C goal. And similarly, I think the idea is with injury to the pancreas, if you have relative insulinopenia, the sulfonylureas may not be as effective, but I will still use low dose again because they're cost effective in my patients that have some degree of pancreatic insufficiency. Gail, any other final thoughts about that?
No, you summed it all.
Okay, great. That gives us time now to go on to our great case. So go ahead, Kim. Jessica will share your slides and let's go ahead and start our great case. I will go ahead then and just sort of summarize her case, and hopefully she'll be able to jump back in with us, but we know sometimes those things happen, right? So I'll do the best I can with the case presentation. So this is a 47-year-old woman who was diagnosed approximately 2014 at age 38 with type 2 diabetes. She was started on metformin, then escalated to glipizide, and then on sitagliptin, but she still remained uncontrolled. And so then in 2018, she was initiated on insulin. She then developed symptomatic hypoglycemia when she was on insulin. So then in 2022, our semaglutide, or brand name Ozempic, was started. One of the confounding things is that she's had some problems with having her insurance cover it. And so she has been on and off of the semaglutide, which is a common story we hear. And it sounds like Kim got kicked out and is waiting to be led into the meeting. So for some reason, Jessica, can you let her in? And I will continue. So she's had intermittent access to her semaglutide, and even without the insulin on board, so she was able to come off her semaglutide, she then still seemed to have on her CGM readings low blood sugars. Although she, because of her busy schedule and where she works, she was never able to finger prick to confirm a truly low blood sugar. And my understanding is these weren't necessarily symptomatic when she was just on the Ozempic and then even just on the metformin.
Hi, Nicole. I got back in.
Okay, awesome. I don't know why that happened. I just summarized the first part of the case that was about her medications. And so I don't know if you want to continue on with her labs and the rest of her and her goals and everything. Go ahead.
So in terms of her goals, she's very dedicated. She comes to her appointments with our nurse every 2 weeks for her CGM readings. She really wants everything controlled, but at the same time to minimize the GI side effects and, if possible, minimize injections. She was on basal bolus insulin for a while and was still above target for A1C and still having hypos, particularly due to forgetting to eat. And when that was the case, they were symptomatic. So we slowly switched her over to Ozempic and was able to very quickly stop the insulin altogether. And things were okay until we tried to up her Ozempic to 0.5 milligrams a week. She got a lot of GI side effects. So then we had to stop on the Ozempic, and then she was only on metformin for a while because of that. Metformin was not enough to control her sugars, and she really preferred the Ozempic over the insulin. So we attempted to try the Ozempic again, but around that time, that was when Ozempic was in really short supply. It was really hard to get, and so we would try other GLP-1s, and she again had those GI side effects. And recently, and then she lost her insurance, but now she has insurance back, and she was able to restart the Ozempic. Now, the information I'm going to give for the rest of this case, though, is actually based on when we were unable to restart Ozempic, and insulin was a lot cheaper because she didn't have insurance at the time. And so this is how her body reacted to insulin. In terms of her medical, yep.
Oh, I was just going to say, and just go over her labs briefly. I think the next slide is her tracing. So.
Yeah. So for her labs, she has, so the A1C non-fasting the glucose non-fasting was high. Her A1Cs, both venipuncture and point of care, have been in the 9s and 8s, depending on the month. And her creatinine is great, 0.56. Cholesterol is just mildly elevated, LDL at 107, HDL at 45, and the triglycerides at 126. In terms of her liver numbers, they're a little bit elevated. They are trending down from previously, and she does have some urine albuminuria. In terms of her social history that would affect her diabetes, she works in a fairly active job. She works in the airport. She does food service, so she's on her feet all day. She is married with good support from her partner, and she does not drink or smoke or use other drugs. And then her BMI is just a little bit on the higher side at 28. So to go into kind of what her habits for eating is, she typically wakes up at 5 a.m. and starts getting ready to work because she works very early. When she takes her basal insulin at 5 a.m. when she wakes, but she doesn't eat until around 9 a.m. when she's already at work. And at that point, she does her mealtime insulin. Her meals are typically for breakfast, some sort of bread, either store-bought or ones that she makes at home, and she takes it with avocado. She gets off work around 1 and she goes home and has lunch at home at 2 p.m. And typically that is injera with vegetables or meat on the side. Injera, for anyone who doesn't know, is I would say a bread. It's a grain-based, yeah, I would say bread that's similar to maybe like a tortilla or a roti, because it's made flat into a circular shape, and then you dip it or you put other food into it and you roll it up. And then she has dinner around 5 or 7. She has a cultural stew that she eats, and she typically has vegetables in that stew. And then she goes to bed at 8. Some of the difficulty has been the difficulty with eating. Sometimes she doesn't eat as much, and then that's when she might have a low, especially if she doesn't have a big dinner. She might have low overnights. However, as said before, she has not been able to confirm any of these lows with finger sticks. So when they're asymptomatic, her CGM goes off and she takes a little bit of sugar to help bring it back up. But when she's asymptomatic, we do not know if those are actual lows. And here are her sugars to show that. So I do want to say that for the medications, for the CGM report, she was not on Jardiance at that time yet. So this is with Lantus 25 units BID, Novolog 5 units as her anti-hyperglycemic medications. I'll say the insulin regimen is a bit abnormal in that there's a lot of basal compared to bolus, because when she was previously on insulin, she had so many hypos that we just kept her her mealtime insulins kept being decreased. And so that's how we got to where we are now. And so here in these readings, you can see that her overnight from around 12 to 6, they're in range and they dip down low a little bit. And then at 9, when she has her breakfast, it spikes and it comes down. And then it can sort of get low again between lunch and before she has dinner. And then when she has dinner, it goes back up.
That was a great case presentation. Thank you so much for that. Are there any clarifying questions that people would like to ask?
I have a question. The metformin was discontinued due to GI side effects. Was that the extended release?
Yes.
I have a question about, and maybe you don't know this offhand, but platelets, are they in kind of a normal range or were they out of range?
So I actually went back to look at her chart recently, and she actually hasn't had a CBC in a number of years. Her last CBC was about 3 years ago. And at that time, the CBC was normal.
Great.
I had one more question and then I'll let Gail ask a question. Has she serially had elevated albuminuria? Because the 200 is pretty high. Has that been repeated over time?
That one is a recent one. Let me pull up her chart to see if that happened fairly quickly or if it was a slow process.
Just because sometimes because she's still maybe having a menstrual cycle, sometimes when you see that rapid change, it can be contaminant like from blood, or if people are very physically active and exercise before, you'll see as an error, and that's the natural physiology. So we usually like to see 2 or more. So.
And then I see a chat question as well. She does not have a lot of sugary drinks while she is working. No.
Perfect. And Gail, you had a question as well?
Yes, I noticed on, I guess, days 14, 15, 16, and 17, her tracing looks a lot better. What was the change with that in terms of her CGM?
Oh, yeah, those days specifically, I believe she was sick, and so she wasn't eating as much.
Okay.
And we'll turn it over to Laura now because we have a lot of case discussion to go over. Go ahead, Laura.
Thanks, Nicole. Just to recap, we have a 47-year-old patient with uncontrolled diabetes who's been intolerant to semaglutide due to GI upset and metformin. And then there's this kind of lingering issue regarding hypoglycemia with with her insulin. She's on empagliflozin, Lantus, and Novolog aspart with meals. Her A1C was quite elevated, and as I mentioned earlier, she does have hypoglycemia that's being noted on her CGM. She also has hypertension, hyperlipidemia. She's on treatment for those. She's got this thyroid nodule, hepatic steatosis, and heartburn on omeprazole. And it sounds like because of her job, she can be inconsistent with her meals, and she has not been able to confirm the hypoglycemia readings with a glucometer. So great. So what information for every patient with diabetes do you need? Waist weight and waist circumference, kidney function, age. Do they have a family history of diabetes or autoimmune disease? Are they on medications that increase insulin resistance? What is their lifestyle, job, diet, activity? Insurance, also a consideration. Do they have other complications from diabetes? And cardiovascular risk. So for this patient, she has a BMI of 28. Her kidney function, GFR, is over 60. She's 47 years old, no known family history of autoimmune disease. And again, she works at the airport and consistent meals. And it sounds like she's pretty active, though, with her job. She has Primera insurance.
Great. And so, we're talking about partnerships. So we first want to prioritize, what is affecting her daily life the most, which is her low blood sugars and then her sensitivity to the medication. So those are the two things we're going to put on the forefront to partner with. And right now, she probably has a fear of hypoglycemia. So I'm actually going to turn it over to our mental health expert, Dr. Paul, to talk about addressing fear and hypoglycemia in this population. Go ahead, Paul.
Thank you so much. Yeah, so when I first looked at this case and we thought, one of the things actually in the list of things that you want to ask patients about with diabetes, I would also add you want to check to make sure they're not depressed or have an anxiety disorder. And I saw that she did have a PHQ-9 done and it was 6. So we don't believe that she has major depression. But if we think about what might be going on that might not be asked, if you look at this list, there's a discussion of the possibility of fear of hypoglycemia, or at the very least, where we kept seeing hypoglycemia in quotation marks. So the CGM would show it, but we didn't have confirmation from a finger stick or otherwise. The question, though, is historically she had some hypoglycemic episodes. And I think we have to assess two things. So I always like to think of this as TFA, thoughts, feelings, actions. So sometimes we start from the end, we just look at actions. And if the person has, they've changed their behaviors around their diabetes and they're riding high blood sugars, and we have heard that they've had prior hypoglycemic episodes, it's always useful to ask them if that has happened, a 911 call, or has there been an embarrassing event. Actually, if you go back one slide, please, just back to here. So very commonly, we'll hear about people being at work and they weren't recognizing they were having a low blood sugar, or they actually passed out in public or embarrassed themselves somehow, or they're really afraid. They have a toddler at home and they're afraid they'll have a hypoglycemic episode, or while they're driving. I've had so many patients who've had near misses or even accidents with hypoglycemia. It can affect their thinking. Of course, people are always worried about being hypoglycemic in the middle of the night or during sleep. Or we hear about a lot of irritability, and they lose control of their ability to control their irritability with family members, and they feel shame. So next slide. So what you can see here is there's a measure called the Hypoglycemic Fear Survey. And this is not the only one, but this is a fine one to use. You don't necessarily have to administer the whole thing. You could use it as a semi-structured interview. But on the right, you see here, to avoid low blood sugars, I might eat a large snack or try to keep my blood sugars over 150 or limit my driving. I stay home more than I'd like. And those things are good to know. So even for somebody like this, I just heard hypoglycemia so many times in this, it would be good to find about their behaviors. But again, thoughts, feelings, actions. We're talking about the behaviors that have changed. I would go back to do they have concerns or fears that thoughts that are driving them to have fear and anxiety. So such as not recognizing or realizing that I was having a low blood sugar, not having food, fruit, or juice available, passing out in public, and I already read some of those. So they develop worries, and those can be anything from obsessive ruminations or anxious ruminations to even sometimes traumatic experiences that people have had. I've often had patients come to me for the first time and they had one episode, they had a 911 call, they were horribly embarrassed, but they have intrusive thoughts after that. And they really do need more than just acknowledging their changed behaviors, but we really have to address their underlying worries that can become ruminations and fixed ruminations. So I would say that it's worth exploring that, sometimes using a questionnaire, either giving the person to the question or just using that as a framework for asking them questions. And again, thinking not just about the behaviors, but the underlying worries. And then, of course, you also might want to administer the GAD-7, GAD-7, which is an anxiety measure. If they also have anxiety, all of that is going to be significantly amplified. So I'll stop there.
Great, thanks so much.
Sure.
So our second question, does this person produce insulin? Nicole?
So, this person made me think about whether this person could be a type 1 or type 2 just because of her earlier age of initiation. We didn't know her family history for type 2 diabetes, so I do think type 2 is still more of a possibility. But because of the earlier onset, I would at least consider her being a potential for being insulinopedic rather than insulin resistant, especially because her BMI is only 28. So in the future, if she's not able to come off of insulin, if she's having worsening sugar control despite being on a semaglutide or an alternative agent that doesn't cause a GI distress, and her blood sugars go from controlled with no change in her nutrition or activity to uncontrolled, this is someone that I would screen for type 1 diabetes. And how do you do this? So next slide, please. The ADA actually has given us more good direction on how to screen for type 1 and type 2 diabetes with a new figure. So next slide. First, you assess your pretest probability, and that is age, family history of autoimmunity, or type 1, personal history of autoimmunity, their BMI, and then also, like I said, if they're on 3 or 4 medications and they're still uncontrolled with insulin-sparing agents, that's who I would screen for type 1 diabetes. Because unfortunately, 40% of patients are misdiagnosed first as type 2 when they really have type 1 diabetes. And then this is a very busy figure by the ADA, but very helpful in the sense that they say if you have a high pretest probability, you can screen, and I think about it in terms of like genotype versus phenotype, going back to 8th grade biology. So our genotype is our GAD antibodies, or the most common antibody we screen for type 1 diabetes. That's our risk of having the disease, right? But then our phenotype, or the penetration, is our C-peptide. As Gail mentioned earlier, that's a precursor of insulin, and so you can draw it when someone is on insulin and still get a marker of your endogenous function. And what the ADA has done is it said that you can just draw a random C-peptide within 5 hours of food, and if it is above 1.8, then it's considered adequate reserve. I myself like to draw the C-peptide about an hour or two after you eat, because then in the setting of a sugar of 200, and that's, you do want to draw glucose as well, if the C-peptide is less than 1, then you have this objective data point to tell people that they may need insulin. And so in her case, I think we're okay just monitoring and keeping it in the back of our heads, but I would have a low threshold to initiate this lab evaluation. Thank you, Laura.
So sorry, thanks, Nicole. Our third question is, what is her A1C goal? And I'm going to hand this over to Dr. Nunley Bland.
So, being that she has some hypoglycemia as well as severe hypoglycemia, we're not as stringent in terms of our A1C goal of less than 7. So it may be worthwhile targeting her A1C between 7.5 to 8%. And the ADA has put out these guidelines for us that makes it where we individualize the treatment of our patients so that not everyone should be targeted to less than 7 or less than 6.5 as proposed by ACE. So this is a good guideline for that. Next slide. And as you can see here, The ADA uses less than 7 as the optimal, but ACE is a little bit more stringent and less than 6.5. And as you can see, the target ranges between the ADA and ACE are a little bit different. ADA anywhere from 80 basically to 180 2 hours postprandial, and the ACE uses less than 110, which is pretty rigorous, and no higher than 140. Next slide. So self-monitoring of blood glucose can give you an idea, although it's just a snapshot in time. But if you do it at different times of the day, and sometimes for those who are not on a CGM, I might tell them, check your blood glucose before breakfast, but then another time before lunch, before dinner, maybe do some 1 or 2 hours after you eat, so we can get a composite or an average of what your blood glucose is throughout the day if you are not on a continuous glucose monitor. Next slide. We use a lot of the ambulatory glucose profile report, and what I generally do first thing is if they're fortunate enough to have a personal CGM and we can upload it or we can see it through our dashboard, I first look at what is the percent time they have it on. And generally you can get good data if they wear it at least 70% of the time. Ideally, 90% of the time is where the goal is. The other thing is I quickly look to see, are they having low blood sugars on that CGM? And anytime your lows exceed 5% low, then this is something that we need to address. So generally less than 70 is considered low, and less than 54 is really, really low. And so that generally 1%, it should be less than 1% for less than 54, and really no more than 4% of less than 70. So as you can see in this one here, this person has frequent lows, and that we would need to address that. The next thing is I look at target and range, and generally we like that to be 70% of the time that you're within target. And then your high should not be more than 20-25%, and which the 180 is the cutoff for high, and then extremely high or very high is greater than 250. And again, that should not be more than 5%. And then you can look at your average glucose, which tells us what the average blood glucoses are over the range of time. Generally, these devices measures your blood glucose every 5 minutes, and you can get the average there. And the glucose management indicator is a calculation that gives you a rough idea of what your A1C would be. So it is a calculation, but it is not exactly going to be the same as an A1C. And then glucose variability is extremely important. It should be less than 36%, because if it is more than that, then that tells you that you have wide variations. And that's where that A1C may look okay, but then the patient's blood glucoses are swinging from 300 down to 50. And then that's going to give you that glucose variability or those wide swings, which is not good. Next slide. So this is their CGM. And when we look at her, one, she's wearing it. That's good. 92% of the time she has it on, so that's great. I look at the lows, and she's not really having that many lows based on her CGM. Between the 54 and 69 is only 3%, and less than 54 is 1%. So it seems as though when you actually look at this patient, she's having a lot of highs. 25% of the time, she's between the 181 to 250, and very high 12% of the time. And when we looked at her CGM tracing earlier, you could see she had a lot of postprandial increases in her glucose, which may be contributing to her high A1C, that she has a 9 or 9.6, I believe that it was, that she was. Now, her glucose management indicator, again, is a calculation, but if you look at her glucose variability, that's 41%. And that tells you she's having wide swings in her blood glucose, particularly, I think, on the high side, not so much on the low side, but mainly on the high side. Next slide. And that was her A1C of 9.5%. So there is a disconnect between that A1C and her GMI, glucose management indicator. Now, what can cause A1C elevations? Well, iron deficiency, and we don't know anything about her menstrual cycle, but that may be a reason why we may have higher A1Cs than what we would see on a GMI. Most of the time, the A1Cs and the GMI are very close and usually within 0.4 to 0.5% that they should be in. Hers is almost, I guess, more than 2%. So that would be something that I would explore and look at her CBC and ferritin levels to see if she happens to have iron deficiency. Also, B12 deficiencies can do this. Long-standing metformin can do that. CKD can also be associated with higher A1C, uremia, alcoholism, hyperbilirubinemia. And then the medications, large doses of aspirin and chronic opioid use can be associated. And then also you have to be aware that your A1C can be falsely low. Those with hemolytic anemias can cause that. Chronic liver disease, there are a whole host of medications, including vitamin C, vitamin A, and trimethoprim, sulfasalazole. Those can do it, hydroxyurea. And you should also know that anyone that is homozygous for sickle cell, SS disease, or any other homozygous sickle diseases, you should not use an A1C. And you would have to use other methods of assessing what their overall, including glycated albumin would be one of those that you would do. So, what are the CGMs that we have available? You can have the personal CGMs, which appears as what she has, and there are two on the market. The Dexcom G7, which is great, and it looks, you just apply the sensor to the arm. You can see it on your phone, or for those who do not have a compatible phone, there's a reader that goes with it. And the Freestyle Libre 3, and again, this one is really nice because you don't have to scan it. The other ones, what we call intermittently scanned CGMs, the two, the patient may not scan all the time, so you may have missing data. But the threes, once you put it on and you set it up, you can see your blood glucose in real time. It alerts you when your blood sugars are going high or low. And so this is very helpful in patients in terms of their management. We also have the professional CGM, and we use this a lot in our office for those who, one, do not have a personal CGM, or their insurance companies do not cover it, or they do not want to wear a CGM all the time. And there are two on the market, the Dexcom and the Freestyle are on there. Now, these are blinded, which means that generally a nurse or a medical assistant puts them on. They wear them for 7 to 14 days. They bring the device back and they upload it, and then the provider can review their data to see how well they're doing. And this has been useful for detecting, and we've used it quite a bit, where we've had unrecognized lows. Patients were going very low at night. They didn't know it. And so for those who do not want to or can't afford the personal CGMs, this is a tool that really offices can have and can give you a lot of information, and you can make adjustments. Medicare does pay for this. You can do it once a month, and when you're making those treatment adjustments.
I think this slide may be missing some components, but non-pharmacologic would be lifestyle and nutrition, specifically with exercise, at least 150 minutes per week of moderate to vigorous cardiovascular activity. For the nutrition, working with incorporating a dietitian or a diabetes educator to help with that piece. So in this situation where our patient does have an elevated BMI, what I would say is, never solely, I know we use it a lot in medicine, it's an easy thing to do, but BMI can sometimes be inaccurate in patients who have increased muscle mass. So in my setting in an obesity clinic, we usually will incorporate waist circumference as part of that evaluation. But when there is an elevated BMI, overweight, or obesity, you always also want to be considering if there's other really overweight, obesity-related comorbidities. So this patient does have hepatic steatosis, high blood pressure, high cholesterol, and heartburn, and her BMI is over 27. What I would possibly consider, though, is has she been evaluated for sleep apnea, and of course screening for depression and anxiety, as my psychiatry colleague mentioned, that's important as well. But also binge eating. Binge eating is very, very common in overweight and obese patients with obesity. So in our clinic, we usually use it's called the BED7 questionnaire. And what I would say, if there is elevated BMI and you've evaluated for comorbidities, The other thing that you want to, consider, especially if you're thinking about recommending intensive weight loss, is if they do have really unstable mental health or active disordered eating, I would definitely not recommending any intensive weight loss measures. It's just much harder for patients to kind of follow through, and sometimes intensive weight loss measures like food tracking and things could be, triggering and make things much worse. But for this patient who has these comorbidities with an elevated BMI over 27, based on our ACE guidelines, I would recommend a 5 to 15% weight loss because that should help with blood sugar reduction, improve her heartburn, and help with improving fatty liver disease, reduce blood pressure, and help with her hyperlipidemia. And this is a slide here, the ADA algorithm for screening. And I know the patient has a diagnosis, but what would be helpful is I think if we can actually give her a FIB4 index. And to do that, we will need platelets. So I think having a CBC to see where she's at. Assuming that it's normal, this patient is still kind of in that low risk, which would correlate to kind of a mild fibrosis. But I think for sure for this patient, just to evaluate her comorbidities, we'd want to get that CBC. And then this is from our ACE guidelines, managing fibrosis, managing non-alcoholic fatty liver disease and diabetes. And again, for this patient, she's probably lower risk. So we want to, work on optimizing her glycemic control. These medications here, if there's cardiovascular disease, so GLP-1 receptor analog, SGLT2 inhibitor, if there's heart failure and CKD and SGLT2 inhibitor. Sorry, this is I think the slide was the one that got missed earlier, so apologize. But the other things with nutrition that I wanted to mention also, especially when patients with diabetes and overweight and obesity, vitamin D deficiency is pretty common. The adipose tissue can impair how vitamin D is activated. So I definitely recommend screening. Also, thiamine deficiency is common in diabetes, type 2 diabetes and obesity as well. And of course, we've heard, metformin can also reduce B12. So those are the other nutritional consideration. And another thing in terms of activity, I mentioned 150 minutes per week of moderate to vigorous activity, but you want patients to kind of go slow and gradually build up. Even 5 to 10 minutes walking after a meal can be very helpful. Many times in our clinic, we will also engage physical therapy to help patients just start movement safely, but of course also prior to any activity, if there's any concerns for any active cardiac symptoms, you'd want to screen for that and have them evaluated before the patient starts a program. And then this slide kind of goes over how we can, I use a lot of the GLP-1 receptor analogs in weight management. Of course, they're very commonly used in diabetes, but these side effects can sometimes be hard to navigate. In my practice, so thiamine deficiency in obesity, again, it's common. And one of the symptoms of that deficiency can be nausea and vomiting. So we, in our clinic, we actually do, monitor this level, but oftentimes to help patients when they're retrying these, I will put them on like a thiamine supplement for at least 2 weeks prior and while they're adjusting. And sometimes that does seem to make a difference. Very, very important. These medicines make food just move much slower through the gut. So patients must do small, frequent meals, use small plates, smaller utensils just to kind of slow their eating. The brain, through reward, can kind of still drive eating. So the patient just has to be, extra mindful in terms of the small portions. Really greasy, fatty foods also, they're just a little heavier. And, when we eat them and when you're on a GLP, it's going to just be sitting there a little bit longer. So patients can usually have more upset stomach with really greasy or fatty foods. With the semaglutide, it sounds like this patient was able to get up to 0.5, but couldn't really move up beyond because of side effects. So, potentially you could do a 1 milligram pen, but the patient could, count clicks, just kind of slowly adjust. So with the 1 milligram pen, there isn't a mark for 0.75, but you could, with counting clicks, do a 0.75 dose and then gradually go up to 1 milligram. So she is taking omeprazole for her heartburn. So I think it'd be important to kind of ask, is she taking it on a regular basis? uh, because if she's not potentially, maybe that GERD is aggravating her tolerance. Another thing, that I learned from our endocrinology colleagues here, Dr. Ehrenhardt, sometimes untreated H. pylori can also be one of those things that can pop up that could affect how a patient tolerates these medications. But also, what we've seen in clinical practice is that tirzepatide actually may be better tolerated than semaglutide. It seems there's some effect with that GIP hormone with the GLP-1 can help mitigate some of those GI side effects. So I'm not sure for this patient if she'd have coverage for tirzepatide, but that could be an alternative. And then the other thing I would just say with GLP-1 and weight loss in particular, and this patient already has kind of she doesn't have a very high BMI, but we don't want her to, lose muscle while she's losing weight. So, working with the dietitian, I think is important, but I usually recommend protein every meal, every snack. And a dietitian in particular can give them specific targets, like how many grams of protein do they need based on their ideal body weight. And I find it's helpful for patients to track foods while they're on these GLPs, so they remind themselves to eat, but also they can track their water and things. Nicole?
So we're a little over time, but I wanted to round this out to talk about insulin because her main fear is hypoglycemia. So let's assess her insulin use critically, okay? She's on glargine. It has been reduced appropriately to 20 units twice a day when she was having hypoglycemia, and her Novolog is at 5 units TID with meals. Currently, her weight is 157 or 71 kilograms. So what does that mean? It means she's taking somewhere between 0.5 to 0.7 units of basal insulin per kilogram, which is a fairly large dose, and she's only on 0.2 units per kilogram prandial. So let's explore that a little bit more. This is where the first and everything you want to ask them is how many units of insulin is she actually taking in a day? So I tend to ask people, oh, if your blood sugar is 120 at bedtime, do you skip your insulin dose? Or what level of blood sugar would you skip your insulin dose? How many times a week might you miss your insulin because you're scared of low blood sugars? We just want to best figure out a starting point for your insulin. So let me know, how many units of insulin do you think you're actually taking in a day? And also, I ask them if you have to snack to maintain your blood sugar, because you don't want to have to do any of those things on your insulin dose. So next slide, please. We again talked about not being afraid to use insulin early. This person is not catabolic though, so what we want to do is replace her insulin with insulin-sparing agents if possible. Next slide. So we know that we'd love to use some glutide or tirzepatide, but she's had intermittent coverage of her insurance, so that may happen again. And then also she's had these GI side effects that we may be able to mitigate, but we're not sure. But the primary thing we want to do in this patient's case is avoid the overbasal, okay? For many years now, the ADA and the ACE guidelines have highlighted that there's little benefit for going over 0.5 units per kilogram for basal insulin. And this person is on more basal insulin and very little prandial insulin. So next slide, please. The ACE guidelines highlight potentially using a weight dose starting point. So many people will start at 10 units. And I will tell you, 10 units for a 200-pound person, I say it's like spitting on their diabetes, right? So you want to choose an effective dose. So, but what's a safe dose where they're not going to likely to have low blood sugars? In someone who the A1C is over 8, an average sugars of 180 to 200, then probably choosing 0.2 to 0.3 units per kilogram is the appropriate dose for that patient starting, right? And then escalating it based on their fasting blood sugars. And it may be if the patient is scared of low blood sugars and they may weigh 100 kilograms and you may choose 10 units because that's where they're comfortable. The main thing is what you think will be a safe dose, and then what is the patient comfortable with, and then you escalate it as a paired partnership. But make sure you're choosing the dose and base it based on weight rather than just grabbing 10 units, which may actually be too much for someone who's 50 kilograms. So, go ahead, next slide, please. And so in this person, I would not go over 0.5 units per kilogram. And given her lows, the first thing I would do is de-escalate her basal insulin to 0.3 units per kilogram. So to make it easy, 20 to 21 units. And I suspect she often doesn't take her evening dose because of her fear of low blood sugars. So it may be she's already taking 20, and then I would do 15, okay? And I just want to highlight, what happens a lot of time is we keep escalating the basal because it's more convenient for the patient. But in her case, because she's active, she probably leaves very little basal, but because of her traditional bread and stews, she may need more prandial. And so I would re-skew immediate when I added prandial insulin to more prandial and less basal. And this is a newer thought process. And so it is something that we continue to educate people on, but I would be more likely to reduce her to 20 and either hold at 5 units 3 times a day. And if we do add in the semaglutide or another weekly GLP-1 or GIP GLP, I might even be more conservative, next slide, and go down even more. Because we can always go back up. And so the teaching is typically you can hold on the insulin dose unless they're on more than 0.5 units per kilogram, then you go down to the 0.5 units per kilogram before initiating the GLP-1 receptor agonist. And then every time you go up on the dose, I usually go down by at least 20%. And in someone like this, because we heard she rapidly didn't need insulin and also her fear of hypoglycemias, I would half the dose. And I would tell her, if you're nervous or you have any lows, just hold it and we'll maximize the GLP-1 and then we'll add back a little whiff of the basal insulin. Or she may not need basal. She may just need, with a heavier meal, 2 or 3 units of insulin. Next slide, please. So in summary, we want to make sure that we best give this person a chance to use a GLP-1 receptor agonist or a GIP GLP-1. So you want to ensure she's taking her omeprazole daily because many people use it PRN and we want it daily to suppress the acid because of that gut slowing. We want to screen her potentially for H. pylori in the stool given her significant symptoms. We want to look at signs nutritionally that might falsely elevate that A1C, B12, iron, and ferritin. And we heard from Laura, thiamine potentially because that can cause nausea. We want to assess her risk for metabolic liver disease, and we want to significantly de-escalate the glargine and potentially hold or even de-escalate the mealtime insulin as we start the semaglutide. And finally, if we're not able to get to an effective dose of the semaglutide, or we are able to get to an effective dose of the semaglutide, but she has significantly worsening of her glucose control, that's when I would screen her for type 1 diabetes. I also think at some point I wouldn't mix the two because we want to get her on, if she's still requiring insulin, once you get her to the maximum dose of GLP-1 or GIP, I would go ahead and do a retrial of a low dose of metformin. And so I'll leave it there. That was a lot of information. So I would just like to say this ends session 3 of the Cardiometabolic Echo. Thank you so much for your time, everyone. Hopefully there was a lot of learning today and so a lot of diabetes. Happy Echo. Bye.